Okay, here we go. Part 3, the final part of anti-infectives. Dropped off at vancomycin. Vancomycin is an oldie but a goodie. It's used frequently for methicillin-resistant staph. It has known nephrotoxicity, especially in conjunction with other necrotoxic drugs. It is politically incorrect for me to say red man syndrome, but if vancomycin is administered too quickly intravenously, your client will just flush from head to toe. Peak and trough levels are used, more so now trough levels, which are levels that are drawn right before the next dose. Come on. Come on, pup. There's a small dog in the room watching me do this. First and foremost, with all anti-infectives, complete the prescription. Complete the prescription. Aminoglycosides, sulfonamides, and what other drug should you be sure? But, just drink a lot of water, period, okay? Just drink a lot of water, period. The macrolides, not real common, but I'm going to make you go back and look it up. A patient has a known allergy to penicillin. What other class may they have a cross sensitivity to? And when I talked about it on part 2, I called it penicillin's first cousin. So we spend a fair amount of time on antimycobacterial medications, pulmonary tuberculosis, Mycobacterium tuberculosis. Pulmonary is a big deal. It, for a while there, had seen a resurgence, especially in the immune compromised population. And we do touch on it a fair bit. The drugs are quite powerful and not specific to TB. You'll see them other places as well, but that's really their claim to fame. Most common isoniazid, referred to as INH, rifampin, and ethambutol. As a healthcare person, if you become exposed to TB and seroconvert, you don't actually have the disease, but your skin test is now positive, or your quantiferin gold test, blood test is now positive, the recommendation is you take 6 months worth of INH prophylactically. Again, I am not going to read slides. The treatment, though, of note, probably on average to treat active TB, talks about here 6 months to 2 years. Probably on average it's 18 months. The first line drugs, the INH, the rifampin, the ethanamide, there are combinations now. Don't get lost in the weeds of prescribing medications. We're not providers. Side effects, side effects, side effects, side effects, side effects. Side effects. So sometimes there are critical, life-threatening side effects, and then sometimes there's just weird side effects. That's fun to know. All of them, all of the anti-tubercular drugs have the potential to be hepatotoxic. So much so that it is critical that while taking them, the client refrain from anything hepatotoxic. Acetaminophen, no. Alcohol, no. So you as a healthcare worker, if you're prescribed isoniazid, INH for 6 months prophylactically, just know, absolutely do not drink. Statistically, there was a lot of deaths associated with INH prophylaxis and alcohol use related to hepatotoxicity, liver failure. INH, most common, hepatotoxic, peripheral neuritis. And you'll learn this later with antidepressants, but INH, you also need to avoid the tyramine containing foods. Remember, there's a list of tyramine containing foods in your drug kit. Rifampin turns all body fluids kind of an orangey red, and your urine will stain your clothes. I suspect your other body fluids will. But yeah, tears, it's kind of cool. But rifampin, orangey red. Ethambutol is famous for causing optic neuritis. Not a good thing. Ethambutol eyeballs. Again, I think we've seen this before. Finish your prescription. Ethambutol is the vision one. Rifampin is the orange color one. Liver. So antifungals. Now I'm going to get a little quick here. Just understand from your microbiology, fungi, bacteria, virus, different. Fungi, bacteria, virus, different. Many of your antifungals end in ZOLE. Nystatin, it's topical, it's oral. Ketoconazole, fluconazole. Fluconazole is like the new kid on the block. I think it came out in the 80s. I actually have a Snuggie for my sunglasses from diflucan when it first came out on the market from a promo. Antivirals. And when you hear or think or know antiviral, worry about the immune system. Because they, more so than the other anti-infectives, wreak havoc. And think about it. HIV, virus. Many of them contain V's in their names. Herpes simplex, fever blister to the more complex, RSV in kids, varicella, CMV, cytomegalovirus. I think probably we're all positive for CMV. VIR. So if you see VIR, think antiviral. If you see antiviral, think immune system. Amantadine is a kind of supposed to keep flu from progressing. Acyclovir, commonly used for herpes virus. Now, in the AIDS population, the antiretrovirals Many of them are given in combinations, and now they have combination drugs. So 3 different drugs in one formulation. Reverse transcriptase inhibitors, protease inhibitors, and your nucleosides. Don't get lost in the weeds trying to remember all that. If you end up working with an HIV or AIDS population, it will become second nature. Their combination. Anyway, I'm going to say AZT because I can't pronounce it. It was the first ever HIV drug. Historically, now with this COVID thing, I don't know what'll happen. Historically, it was the drug who made it from clinical trial to market faster than any other drug before. In the clinical trials, the patients getting the placebo didn't come back for their follow-up visit because they had died. Remember, think immune system, but also peripheral neuropathy, bone marrow toxicity. What's the big word for that? Blood dyscrasias, rashes, headache, nausea, vomiting. So a little CNS, little GI. And then antiprotozoals, malaria, giardia. We're not going to talk about malaria, but just know if you are traveling to a country where they recommend malaria prophylaxis, you need to start it like a month before you leave. Anti-helminth agents, worm, mebendazole. If you were ever a kid, well, if you were, yeah, you were a kid, but you probably don't remember. Or if you have kids,